Thanks everyone for joining our webinar tonight on the new solutions for nerve pain and diabetic neuropathy with Dr. Evan Lewis. Dr. Evan Lewis has created and has done lots of really excellent research on a new brain and nerve friendly omega-3 product that has been shown to improve pain in neuropathy, so nerve pain, and also specifically diabetic neuropathy by the ability for the nerves to regenerate, which is something that is super important in this condition and in general, and then also one of the biggest missing links in diabetic management for patients that have diabetes. So with all that said, I'd like to welcome Dr. Evan Lewis to the webinar tonight and thank him so much for being able to join us and present this really groundbreaking research. And so with that said, I'm going to pass the ball over to Dr. Lewis, and then I'm also going to allow him to tell you all a little bit more about himself as well, and so you get a context and framework for who he is and where this research came from. And I know that there's a slide early on with some super cool pictures as well to show you truly who he is. So, Dr. Lewis, the ball is passed over to you.
Welcome, everyone. I'm very excited to be here this evening. I've been working with Gavin and Heather and the team at Biomed, and we've been working together to bring some new therapies to all of the practitioners that are part of the Biomed family. So this is just a great honor to be here today. So a little bit of an introduction about me. My background is in exercise physiology and sports performance, and I started my research career as transitioning out of being an athlete. I was on the Canadian sailing team for 3 years, leading up to the 2012 Olympics. I wasn't quite in a position to go to the Olympics, so I chose to pursue a career that was as close to that as possible in terms of making athletes function better. And after I did initial work in sports performance for my master's, I transitioned into focus solely on nutritional sciences at the University of Toronto. And my area of interest started from work with athletes, because really our rate limiting factor for movement or performance comes down to nerve health and nerve function. And from initial work with athletes, I then started to work with different neuromuscular disease groups, which is what led me into work with people with diabetes and diabetic neuropathy. And since finishing my PhD, I'm now actually doing a postdoc at Mount Sinai Hospital in Toronto in the Leadership Diabetes Center there, and focusing on diabetes complications and the role of nutrition therapy. Outside of the lab and outside of doing all this other work, my family and I live on a hobby farm just north of Toronto, where I get to hang out and play with my rescue draft horse, whose name is Storm, as well as my daughter and my wife. So what I want to do for tonight, our objective is to try and bring everybody up to speed on what is neuropathy, how does it develop, who gets it, as well as what are the basic nutritional requirements in terms of using therapy for neuropathy. I'm going to give an overview on my clinical research, which led to the products that Biomed is now carrying. And we're also going to discuss how to implement this into your clinical practice, tools to measure change in neuropathy, and also some ways to address different types of neuropathy, along with the general family of Biomed products. And then I'm more than happy to answer any questions at the end of the presentation. So to start off, what is neuropathy? And neuropathy is a clinical definition for nerve damage, and it has a natural history or a progression that comes over time. And it starts with damage to small nerve fibers. And these are the ones in the hands and the feet, which are unmyelinated, so they're not protected and can be very easily damaged by high blood sugar or toxins. And with it can happen slowly over time that this damage occurs, and it starts slowly, especially at the most peripheral end of the limbs, and over time progresses more proximally towards the middle of the body. And excuse me, from a clinical standpoint, what we have, or what we refer to it as, is a glove and stocking presentation. So starting at the toes, working up the ankles and shins, or starting at the fingers and working up the forearms. And that's where you might see clients discussing that they have maybe a little bit of numbness or tingling in a hand or a foot, and that would be those early first signs and symptoms. As neuropathy progresses over time with longer exposure to different agents, whether it's blood sugar or toxins, we start to see more involvement of large nerve fibers in addition to the small. Partly because large nerve fibers are myelinated, they take longer to develop damage. So that is one key aspect to see an intermediate progression. And if you have a client that is dealing with neuropathy, this intermediate stage is typically where a traditional MD specialist diagnosis of neuropathy will come through because they require abnormalities on a nerve conduction study in order to make that diagnosis. And finally, and someone with advanced neuropathy, they have obviously both small and large fiber involvement, but that's where we start to see other complications, whether it be in the cardiovascular system. We can see some autonomic neuropathies, so changes in control of heart rate or reduced heart rate variability, but also other complications with increased risk of wounds, a presence of wounds, ulcers, and that leads to ultimately the biggest concern, which would be an amputation. So the ideal intervention, as we all know, is we want to try and stop a problem from happening before it develops. So if we can detect or even identify somebody who's at risk of developing neuropathy, then we want to try and intervene as quickly and as early as possible. So who gets neuropathy? And there's a number of different types of neuropathy, but the three most common, or the three largest groups, are those with prediabetes, diabetes, or chemotherapy. And the real surprising thing that we're seeing more and more clinically is people with prediabetes are actually getting recognized or getting a diabetes diagnosis because of their pain. And I just want to highlight the abbreviations at the bottom, DSP plus and DSP minus. That's an abbreviation for diabetic neuropathy or neuropathy. So about 25% of those with prediabetes will experience neuropathy symptoms. And oftentimes, their prediabetes has gone undetected, and especially if you think about males who don't typically go to see a family doctor, that's really, finally that pain in their foot is what really drives them to get help. With diabetes itself, about at least 50% with diabetes have neuropathy, and those numbers are slowly starting to increase as our diabetic population is starting to live longer. And the other interesting one is individuals with chemotherapy. At about 6 months post-chemotherapy treatment, we're seeing about 60–65% of individuals with peripheral neuropathy as well. So the real scary statistic is, going back to focusing on people with diabetes, is that over 50% of those with diabetes will develop neuropathy within 10 years of their diagnosis. And our biggest challenge is that our clinical practice guidelines right now are truly letting down people with neuropathy. So if somebody in our traditional medical system is seeing their family physician, they've been diagnosed with diabetes, what recommendations they receive are to stop smoking and start exercising, which is great. We support this fully. The next is blood sugar management, and that can come in the form of nutrition counseling, which can be a whole nother discussion on that, or the introduction of blood glucose management medication. But the biggest challenge and one of the main inspirations for my research is that none of these practice guidelines actually address the fundamental nerve damage which is going on, or provide a solution with which to rebuild. So when somebody develops those neuropathy symptoms, there is a very well-defined pathway for prescription medication that deals with symptoms only. And that starts with fairly mild, minor drugs that relieve symptoms. And for those that need it, I think that's fine. But ultimately, all that happens is symptom management, and we're not actually addressing the underlying cause to the problem. And just as another sort of side note around that, if we look at the most recent clinical trials of agents for neuropathy, they've, over the past 10 years, have generally been unsuccessful in supporting nerve regeneration. But all of the studies that have looked at pain management or dealing with suppressing symptoms, those have all been positive. So it really leaves clinicians not much of a choice at this point in time. So how do we try and break this cycle? How can we actually support nerve health and really fix the cause of the problem? And from my early research, looking at nerve health and the composition of different nerves, nerves are made of proteins, water, and fats by and large. And if we look at the fat breakdown, the two essential components to nerves that we can't source, that our body can't make themselves, are omega-3 and omega-6 fats. And we have to source those from our diet. They're essential fatty acids. And right now, if we look at the population on a whole, our diet is very high in omega-6 fats and very low in omega-3s. And if we don't have sufficient omega-3s, then we can't maintain our nerve health overall or support nerve regeneration. And looking at, some of you might be familiar with nutritional research around neuropathy. There has been some good work with other nutrients such as benthionine, carnitine, alpha-lipoic acid. Those seem to do a good job in terms of symptoms, but not actually addressing fundamental nerve damage or nerve regeneration. So if we start to think about omega-3s as being the rate-limiting fat in terms of nerve health, what do we know overall about omega-3s for nerves? And there's a number of different factors that can go into this. And here I can have a nice summary slide drawing from some clinical human work, healthy population work, as well as some more animal model data. But what we know is that starting in the bottom left corner with the dietary imbalance, yes, on the whole, our population is low in omega-3s, but specifically, individuals with diabetes have a harder time metabolizing omega-3 fats. So if we take a group of individuals with diabetes and compare them to a group of healthy controls, the the amount of omega-3s in their blood will be significantly lower than the healthy population. So again, that already puts our population further at risk of not being able to address their nerve damage. We also know that on a couple different levels, omega-3s are necessary for nerve growth or turning on nerve growth machinery. Two specific omega-3s I'll get into later are needed for nerve structure or general integrity of any cells. We know that omega-3s are very effective at resolving inflammation, and especially in the light that omega-6 fats are generally pro-inflammatory. We need to make sure we have enough omega-3s to really counter that. And also, we've seen some good work in animal models of diabetes that omega-3s can improve nerve signal conduction and also blood flow, especially along those small blood vessels that feed the nerves. So in terms of the research that we were doing, there's a very good background to support the use of omega-3 therapy as an intervention for diabetic neuropathy, but nobody had done that yet, and especially not even using any measures of nerve regeneration or nerve functioning. So that led into the development of a clinical trial here at the University Health Network in Toronto. And for that, we took a good look at how were we going to choose the best omega-3 to support overall nerve health, nerve structure, and nerve regeneration. So the omega-3 therapy that we used in our trial contained all three of the pro-nerve omega-3s, EPA, DPA, and DHA. And I often get questions at presentations of what about ALA or what about flaxseed, or I take a lot of flaxseed oil or chia seeds. I eat a lot of those. Generally great for health. Those fats are great overall. But what we know is the shorter omega-3s, the ALA, are not involved directly in nerve health overall. And what our clinical research shows is that the conversion of ALA to the longer chain EPA, the enzyme in our body that regulates that, operates at about a 1 to 5% efficiency, depending on the person. And so ultimately, that source of omega-3 is not, I would say it's a non-neural source. Good for health, not involved in nerve health overall. So what we were using had both EPA and DPA, which are both involved in cell membrane structure, so nerve structure, and also are both very anti-inflammatory, have a lot of pro-resolving, are metabolized into pro-resolving lipid mediators. And also importantly, what we know about DHA is that it's able to turn on the nerve growth machinery, which is important if we're trying to support nerve regeneration. So we have all three of these omega-3s, and the structural component of our supplement is in triglyceride form such that it was absorbed in the mouth and the intestines. So we felt this was very most effective, could be the most clinically effective omega-3 therapy for our studies. Now you're probably wondering, how do we do all of that? And the answer is we source these omega-3s from seal oil. And when I started my original research on how could we use different types of omega-3s, the research around structure, composition, and bioavailability or absorption really led me back to the fact that this was from my point of view, scientifically, the most effective type of omega-3 that we could use for our nerve health research overall. And when I highlight the bioavailability factor, you can see here two different triglyceride molecules which are laid out, one from seal oil, one from fish oil. And what we're able to do within our mouth, we have lipase enzymes, which are designed to absorb the third position, cleave and absorb the third position fatty acid in a triglyceride molecule. And the reason for that is that's an evolutionary mechanism that, so when infants are breastfeeding, they're able to take that same position omega-3, absorb it into the bloodstream, and then it goes straight up towards the brain and the eyes, which are both omega-3 rich organs. So fortunately, since we're sourcing a mammalian omega-3, we're able to use that same uptake mechanism. Also, one of the things that I found very important was the omega-3 to 6 ratio. Earlier I mentioned our population is very high in omega-6 fats and very low in omega-3. And this, our omega-3 oil actually has 10 times the omega-3 to omega-6. So it's truly high in omega-3s, which is very important for improving inflammatory status overall in the body. It's important to note, as our company, we work very closely to monitor sustainability and longevity of the seal population in Canada, and that's something that's very important to us. We make sure that we follow all regulations, and all of the sourcing will be available for years to come. In terms of quality and safety, because many people, when I speak at conferences, as one of the concerns that they have in terms of any potential heavy metals, and our omega-3s are held to the same standard as fish oil by Health Canada. So we have to measure up exactly the same as any fish oil omega-3, and we absolutely exceed those standards. And just something that I thought was important, especially which I've shared with Gavin and with Heather, is that we have as a company, we have a 5-year plan to transition our sourcing to work with traditional hunters for supplying all of the raw materials for our oil. So getting back into the clinical science side, so that was the background research in terms of why we wanted to use omega-3s as a therapy for diabetic neuropathy, the rationale for why it might work, and the selection of the source for our omega-3 supplement. So in the clinical trial that we conducted, we used a cohort of type 1 diabetic patients because we selected type 1s because they had better blood glucose control being on pump therapy than type 2s. However, the progression of neuropathy is identical between type 1s and 2, so the results are not specific to type 1. They're generalizable to diabetes as a whole. The objective of the study was to try and stabilize the known small fiber loss that occurs in diabetes, and we wanted to do the same in large fiber. And I'll get into a little bit of the rate of change in terms of nerve loss in diabetes in just a couple slides. Okay, so for the trial overall, we had 4 visits over the course of 1 year, a full physical exam, and then we did a test called CNFL. That's an imaging test for corneal nerves, and I'll show you exactly what that looks like on the next slide. This measurement of corneal nerves was our primary outcome for the trial. So that was repeated at 4 and 8 months, and then we did the full workup on the patients again at 12 months. So the research group that I work with at Mount Sinai, they've been working on this technique for about 10 years, taking it through from testing the concept through to we've just finished up some clinical validity data will be presented to the FDA next year. But we've developed this technique as a non-invasive way to examine small nerve fiber health. And on a research level, previously, to look at small nerve fibers, you would have to take a skin punch biopsy. So for anyone with advanced diabetes, you would actually have to take a chunk of skin and measure that. So it's not as patients don't like it, so we can't use it for research very well. So what our group has been able to do is use imaging to look at the same small nerve fibers non-invasively, and we're able to predict the progression. And what we're able to see is over the progression of diabetes and neuropathy, there's a loss of nerve fibers that's very well characterized. So here we have another slide, and what we know is that individuals who are healthy, they stay stable with their corneal nerve fiber length over the course of a year. Individuals with diabetes, they lose about 1% per year. And individuals with unstable diabetes, we see that they lose about 6% per year, 6% or more per year. And I mean, if I can draw your attention to the bottom image panels in the slide, you can really see a dramatic difference here between over the course of 1 year. So for our study, we had 40 patients, middle-aged, just over half were female, diabetes duration of 2 to 55 years. On average, these patients were generally overweight, slightly hypertensive, but we had a good representation in terms of diagnosed neuropathy. About 60% had diagnosed neuropathy, which meant electrophysiological abnormalities and a range of clinical symptoms. So this Toronto Clinical Neuropathy Score is a rating of pain severity, or how limited individuals are by their neuropathy. For the study, we used a high dose of omega-3s, which was 10 mils per day, broken into 2 5-mil doses, so just over 2 grams of essential fatty acids. And what we were able to show is that individuals, on average, over the course of our study, had a 29% increase in corneal nerve fiber length, which was far above the expectations of our clinical group. We were expecting somewhere between a 1 to 5% change because we were hoping to keep people stable. At the time, we did not think that we would actually see significant nerve regeneration, but we were able to do that, which was very, very shocking for the older MDs on our research team. So that was very, very exciting. Now, I can sort of get into a little bit of the subgroup analysis here. What I've done is broken down how our different groups of neuropathy patients responded. So we had a small group with who didn't have neuropathy, and were at low risk of developing it. So they had type 1, good pump control, generally physically active, generally a little bit younger, and they had a 7% increase over the course of the trial. So really, we took that away to mean that they remained stable. They didn't decrease. We can consider that a stable change. But the 2 subgroups that actually responded the most were those who had evidence of nerve loss from the nerve imaging, but they had not yet been diagnosed clinically. So they were what we call the high-risk group, and they had the best response. And I think my favorite result out of the whole trial is that our group that had established long-term neuropathy, they had all the electrophysiological abnormalities, they responded just below the mean average with a 27% increase. And our population on the whole had a 29% increase. So really what this shows us is that our omega-3 nutrition therapy is not just for those who, in the early stages, who have a few symptoms, but we can actually work to support nerve regeneration in people who have had diabetes for a long period of time. And I can confidently say since the trial, we've seen that time and time again in individuals who've had diabetes for many years, 50 years plus, seeing improvements in symptoms, which is just awesome to see. So how does this work? What's the mechanism of action? Well, I presented a slide earlier on discussing the main ways that omega-3s can interact with nerve health. And I've highlighted here in sort of green what mechanisms came into play. So we know individuals with diabetes have a dietary imbalance. Over the course of the study, blood omega-3s went up over 100%. So we were able to correct an imbalance. Great. We were able to show growth. Again, going back to the fact that we know from animal model studies that DHA is able to turn on that nerve growth machinery, which is awesome. We saw improvements in nerve structure because that was part of the growth pathway. Those cells are needed for growth as well. So our fats also supported the structural integrity with that growth. And we also saw a reduction in inflammation, which is for anyone who's had nerve injury or chronic injuries throughout, inflammation will be present. So those are the four mechanisms of action with which our therapy acted. So taking this out of the lab and to people in Canada, this was one of the things that I never thought of. I thought I would be working in a sports performance company. I never thought I'd be working in a diabetes company. But I was able to commercialize the results from our study and worked with Health Canada to get NPN approval for our product. And you'll note that we do not have any label claims for diabetic neuropathy, nerve health, anything in that area. We need to do more clinical research, which we have planned to start next year. But we are allowed to call our product a diabetic neuropathy supplement, which I think is important because it reflects the research that's gone into it. Health Canada allows us to put the research beside the product and let the consumer draw the conclusion, or allow the consumer to be educated about the research that went into the product. And I think that's a fine way to operate for the time being. And I'm especially thankful because if this was a true drug and we'd had great results, we would have had to go right back into clinical research and we wouldn't be able to help people in the interim. So I'm happy that we're able to help people improve their health while we're continuing our clinical research process. So the big buzzword around the hospital right now is patient-centered model of care. And what we know, I think everybody on the webinar probably knows at least one or two things about how omega-3s can impact health. And the main aspect, or the main evidence-based application for our product, is around neuropathy management, whether it's diabetic neuropathy, and we've helped people with chemotherapy as well. That would be the central aspect, but we can see at least 6 other applications of use or ways that health is improved, not just with neuropathy. And we know inflammation management is a key aspect, lower triglycerides, cholesterol, heart health overall. But the other big thing that we're starting to see, and I just wanted to draw your attention to, is something that abbreviates to NAFLD, which is non-alcoholic fatty liver disease. And this is one of the up-and-coming waves or the next real wave of diabetes complications. And from the research that we've seen so far, if we're able to lower triglycerides, like we know omega-3s can do, then that's a great first-line therapy for stemming the development of that complication as well. So really, one nutrition therapy that helps for neuropathy or manage neuropathy risk, and there's many other positive side effects here. And I didn't even include mental health, which we know there's good evidence for omega-3s for improving mental health as well. So how do we add this into your practice? And I've worked with Heather to develop a series of protocols. Don't worry about trying to write any of this down. It is available straight from Biomed. But here we've highlighted 4 applications of use with the diabetic neuropathy supplement, along with other products, depending on where in the neuropathy spectrum your client might be. So does diabetes run in the family? Is this something they're concerned about? Well, then we can steer you towards the neuropathy risk management protocol. Mild symptoms, advanced symptoms, chemotherapy neuropathy, that's, we have something covered, something developed that will cover you off for all of these different neuropathy situations. I did want to highlight one thing at the bottom. We have two different dosing strategies. And in our trial, we used 10 mils, which is a fairly high dose of omega-3s. And we start to see that recommended when patients or clients have active neuropathy symptoms. That was what's used in the research. That's what the evidence suggests indicates is most effective for dealing with painful symptoms. Any sort of anything mild or on a risk management level, we recommend 5 mils. And likewise, once symptoms improve, if someone has advanced or painful symptoms and they start to get better, then we recommend dropping down to a maintenance dose of 5 mils as well. In terms of timeline for results, what we're seeing right now is individuals with sort of mild neuropathy, those symptoms are improving somewhere between 2 and 4 months. Individuals with advanced neuropathy, like I can't feel my toes, I can't tell the difference between hot and cold water, that takes somewhere between 8, 9, 10 months to improve. And we have helped people actually tell the difference between hot and cold again, which is just crazy to think that they've lost so much sensation, but also amazing at the same time. One of the other questions that I can sometimes get is, here you've presented me with the supplement, it has great evidence behind it, but I'm on, insert omega-3 here. This product can replace any omega-3 that the individual was on previously. And that's something that, they don't need to throw out product that they've bought, but once they've finished off what they're using, then transition over to this here. If in the event that you prefer plant-based options or prefer krill or don't want to work with the seal oil product, I understand that, and that's perfectly fine. That's perfectly fine by our standards. Is there a difference or a performance difference over time? Another question which I often get at conferences, and nobody's going to do the clinical trial that compares the krill or the fish to our seal oil. I don't think that's not really good use of research dollar. But if you choose to not go with this product, there would be over time, you're ultimately putting these nutrients into the body. So there should be a improvement. I just think it would be slower and less complete than what we were able to offer here today. For the practitioners that are using the RebaPad, there's no new protocols that need to be adopted to use with this neuropathy supplement. But depending on the type of pain that your client is presenting with, these are, working with Heather, these are the two options that we've developed to really improve healing and improve uptake. I really think the product would integrate very well with the RebaPad therapy, essentially by providing the fats necessary to support nerve healing and regeneration. I think the RebaPad would accelerate those results. I think it would speed the uptake of the nutrients into the nerves and also help to initiate the repair process while also relieving those painful symptoms. So I'm really excited to get some feedback from the practitioners that are working with the RebaPad. I think that'll be some really exciting results to come there. And the one final thing that I'd like to leave you with, again, this is going to be available through Biomed. There's a neuropathy assessment protocol. And this is something that I found and put into place with the foot care nurses and the chiropodists and the podiatrists that I'm working with. They're a little bit more hands-on in terms of assessing neuropathy using a monofilament exam. So what we've done is for them, we've added this neuropathy assessment protocol to go with that monofilament test to really round it out. If you're not doing any hands-on exams, this is a complete and clinically validated questionnaire, which is able to assess pain as well as the emotional effects of neuropathy. So it gives a lot more insight in terms of where pain might be, how it's presenting. Example question number 9, am I depressed about my neuropathy? And again, that's a huge, for anyone who has a practice that's starting to deal more and more with diabetes, mental health and diabetes, especially around pain, is a huge issue. So being able to get a handle on that is very important. Overall, to administer the questionnaire, reading it to your client and having them answer back, the whole questionnaire takes between a minute and a half and 2 minutes to complete. So I think that's very, very reasonable to include in a visit and get some great data that you can track over time. So again, that's available for download from Biomed, along with the protocol bundles as well. Thank you very much. That concludes my slide portion for this evening. I'm going to try and figure out how to pass this back to Heather.
That was great, Dr. Lewis. Thank you so much for presenting that. And I hope everyone that joined us tonight had the opportunity to learn a little bit more about neuropathy and how the nerves are functioning within the body, and then also the progression of how neuropathy can become kind of that later stage in diabetes and also in other conditions as well. Thank you, everyone, for joining us tonight.
Thank you very much.
Any last words, departing words before we conclude?
One thing we should make clear, the product's only available in Canada. If there's any U.S. practitioners on the webinar, we have something separate that will be coming for you next year. Just we're not able to ship this across the border for some regulatory reasons, but otherwise that's that. Again, really excited to be working with Biomed. So far, our company has been working with foot care nurses, chiropodists, podiatrists, as well as some endocrinologists and neurologists. So really great to be able to expand our reach into other healthcare professions as well. I really think that when we developed the product, it was ideally suited for the clinical environment, just in terms of being able to monitor change and address any other underlying conditions that somebody might have. So again, Biomed's a great partner for us, and I'm very excited about this.
And we're very excited that you've been able to have this available for something we can make available to all the practitioners that use Biomed. And it's a really nice addition to our lineup as well. And as you mentioned about the missing link for nerve regeneration and the ability to support the nerves so that they can start to regrow, giving that opportunity for patients that are having neuropathy and neuropathy symptoms is huge and can be a life changer as far as kind of getting their life back and helping to reduce the pain that's associated with it.
Last, I'm just going to make one more point, Heather, that reminds me. The name of our product and the name of our company is a little obscure. The word Nutarnic is actually taken from the Inuit language, where it means new ice forming in crack in old ice. So we take that to mean regenerative and restorative, and that's for all the products that we have and are developing that's really our mission, to use nutrition as a way to regenerate and restore health.
Excellent. Very great news. Okay, well, thank you, everyone. And thank you again, Dr. Lewis, for presenting to me.
Wonderful.
Take care, everyone.
Take care. Bye.